estaban equivocados. Y alguien me dijo que sí, que estaban equivocados, que los franceses han equivocado mucho tiempo, y creo que la historia está dando la razón de que eso no fue cierto, porque en ese momento el mundo se volcó en buena parte al uso de la doble movilidad y al desarrollo de la misma. O sea que estas son algunas de las cosas que la historia no repitió como muchos lo pronosticaban, y los que usamos hace 15 años software de doble movilidad sabemos que ha sido una de las críticas. El problema fue que la doble movilidad fue diseñada como el implante antiluxante por excelencia, y eso en parte se volvió su castigo, porque la indicación exclusiva era para cuando se estaban luxando las prótesis, y eso limitó su uso a una sola patología. Eso fue su karma. Y lo hacía con base en que había muchas complicaciones por la tecnología de la primera generación de copas de doble movilidad. Y era una copa restringida, pero eso cambió notoriamente con los nuevos diseños y desarrollos con base en el polietileno. Todos sabemos que la movilidad, inclusive con las cabezas grandes, con las cabezas de 40, le gana la doble movilidad, y eso es importante con todos los problemas que han surgido a raíz de la tunelosis con las cabezas grandes. Por otro lado, cuando uno compara entre los diferentes sistemas, encontramos de que a pesar de que haya cabezas grandes, el jump distance, que hablaba Saúl ahora, la distancia necesaria para luxarse entre una cabeza 28 y una doble movilidad, pues requiere casi el doble. Entonces eso hace de que sea un implante muy estable y que permite una gran movilidad. Y eso es importante tratándose muchas veces de otras necesidades que no sean solamente de la luxación. Entonces, rápidamente veamos la teología con relación a los estudios que hay en la lubricación. Hay estudios conclusivos que puedan relacionar cuál es mejor lubricación entre los sistemas convencionales, cerámica, polietileno, metal o doble movilidad. Entonces ahí, como dicen, hay un impacto. Con respecto a la fricción, clásicamente se había dicho que era el desgaste general. Lo que se ha encontrado con los cotilos inclusive antiguos es que el desgaste interno, porque el problema de los cotilos antiguos es el desgaste externo del cotilo, los cotilos nuevos tienen un desgaste semejante al polietileno convencional. Entonces, esto no hay, como dice, ninguna diferencia de 1 milímetro cada 10 años que se tiene equivalente. Y con respecto al pinzamiento, con el nuevo sistema ya hay diferente tipo de pinzamiento que ocurre entre las copas de primera generación y las de última generación. Por eso se conoce como el decalaje, que es como un pistoneo que hace que la cabeza dentro de la copa, dentro del inserto de polietileno, que lo que hace es más o menos esto, que solamente gira el polietileno en el momento en que se tiene el extremo del movimiento, y cuando hace una carga axial ella recupera su centro. Entonces esto hace que el desgaste excéntrico del polietileno sea mínimo y que solamente ocurra desgaste interno del polietileno. La supervivencia día a día, estamos hablando de supervivencias con las primeras generaciones y no sabemos todavía, estamos ya mirando las supervivencias de las segundas generaciones que han superado el estándar de los 10 años más del 90%, y esto ha hecho que su consumo se haya incrementado, inclusive en los Estados Unidos, que eran los principales detractores de este sistema. Entonces, las grandes ventajas, ustedes las vieron, que era pasar primero en pacientes que tenían problemas cognitivos, pacientes en primarias, a incrementar poco a poco el uso de todas las limitaciones, pasando de estos temas de tipo cognitivo, fracturas, posibilidades de luxación, a indicarlo en pacientes que tengan actividades recreativas o laborales que exijan riesgo de una luxación, o por qué no decirlo, porque el tema del reemplazo articular hay que discutirlo, depende de la calidad de vida y depende de la calidad de vida de cada persona. Entonces, un golfista que tiene a los 50 años botarse en el green, a mirar la bola a ras del piso, tiene todo el derecho a solicitar un tipo de implante. Y otros pacientes de alto riesgo, como en el caso de los amputados o pacientes que requieren gran torque. Estos son algunos de los ejemplos. Es una paciente joven, 24 años, nunca se había podido implantar una ortesis, ningún elemento externo, porque no tenía una cadera donde apoyarse. Se le hizo una prótesis de cadera y ese es el resultado años después de que está con el implante, con la prótesis externa colocada. Los resultados cada día son mejores, mucha gente los publica, y los argumentos para aumentar su indicación es que tienen definitivamente mayor movilidad articular, la supervivencia se ha incrementado, entonces tenemos que pensar seriamente en que es un implante para el día a día. Las indicaciones han aumentado a eso, las fracturas de cuello femoral, intertrocantéricas, osteoartritis fallida, yo no dudo en colocar un implante de eso. Y no solamente en alteraciones en las primarias, como les mencionaba, en alteraciones cognitivas, sino también en todo tipo, en algunos casos de displasia tabular severa, en los casos de CROBE 4, donde tiene un riesgo de luxación, hay implantes en este momento que arrancan desde el diámetro 42, como es el caso de la biomobile, que tiene el tamaño 42 y que permite ser utilizada en estas cadenas severamente displásicas. Y por qué no recomendarlo en actividades laborales o en riesgo de luxación. Algunos ejemplos de casos extremos, como es el caso de esta discontinuidad pélvica, donde con algunos sistemas específicos podemos llegar a colocar un implante que sea mucho más seguro, con todo el riesgo de luxación, como en este caso a través del istmo del ilíaco, colocando esta copa, tamaño 50, muy estricto para esa pelvis tan pequeña, pero con un resultado de una discontinuidad pélvica de cura este otro caso, casos extremos, donde hay una pequeñísima, ustedes observan que tenía una Pinnacle 42, una Pinnacle 42, donde se cambia, hay una luxación, se cambia por este sistema de anclaje que solamente va a cubrir en este caso el extremo interno, pero tiene un anclaje, como si fuera un anclaje diafisiario dentro de la pelvis, en el istmo del ilíaco, y cómo conseguimos una muy buena estabilidad. Por eso el futuro está ubicado para estos tipos de sistemas. Está el MACLIN 2 que se ha desarrollado, es un sistema modular basado en MACLIN 1, que es un sistema de vástago intramedular, de copa con vástago intramedular dentro de la pelvis, y que se puede hacer una aumentación, una reconstrucción a través de diferentes insertos, ya sean metálicos o de cerámica, que permitan corregir la longitud y el offset de diferentes copas, colocando, por ejemplo, sistemas que son cerámica, y que el día de mañana con una hydroclean, con una cerámica delta, puedan permitir una longevidad en fricción a estos implantes. Entonces, la copa doble movilidad es el implante antiluxante por excelencia, pero no es solamente para eso. En cirugía de reversión, para mí, es fundamental, y piensen en la doble movilidad en pacientes con necesidades especiales en la prótesis primaria cuando se requiere. Muchas gracias.
Gracias al doctor Javier Pérez. A continuación, el doctor Ramos Charge Cop y conversión de cadena previsión.
Bueno, no es un tópico nuevo, hablamos con ayer con dos presentaciones, so cambia un poco esta presentación, será un poco diferente. So I'll speak about conversion total hip. The description of conversion means that the patient had some kind of hip surgery, open surgery, not hip arthroscopy, before surgery, and now we have to plan to do a hip replacement on that patient. So the biggest challenge in the most common cases, like the ones presented yesterday, are patients that have hip fractures. And the hip fracture fixation, the osteosynthesis failed. Patient has avascular necrosis, malunion, collapse, and now we have to convert it and do a total hip replacement. So that's the most common reason of failure, are the hip fracture fixation. Afterwards, it could be acetabular fractures, and I'll show a case of acetabular fracture. So we have to remember this is not primary total hip. We've shown in many of our work that conversion hips are more like a revision hip replacement. You need the instruments that you do revision hip replacements. You need the implants you use when you do revision hip replacement. Don't plan to use primary instruments and implants when doing these cases. We did a systemic review many years ago looking at outcomes of conversion total hip replacement and to see what the literature supports. And all the literature since has supported these same findings. So if you look at the complications with conversion for failed surgical fixation, and we put together about 300 cases in this review, we saw that the most common reason for complications are fractures and dislocations and infection, and it's not surprising. These are the same complications we see in revision. And it's the same if it was an intratrochanteric fracture or if it was a femoral neck fracture that had osteosynthesis and we then needed to convert them to a hip replacement. The risks of complications are a little bit lower with conversion of femoral neck fractures with the 3 cannulated screws compared to conversion with intramedullary nail or sliding hip screws that were done for intratrochanteric or subtrochanteric fractures, as you can see here. So the conclusion of the review was that your goal is when you convert them is to relieve the pain, because the patient comes to you because it hurts. The osteosynthesis did not work, his function is not restored, he's not back to his normal activities, and we now have to help him and convert this to a hip replacement. Conversion will cost the hospital and the patient more than it costs to do a primary. It will resemble a revision because the implants are expensive, the time in the operating room is expensive, and the risk of complication is higher. So be ready as for a revision. So let's look at a few cases and discuss the pros and the points for those cases. So a 60-year-old male with pain in his hip, he had a previous femur fracture, a tibia fracture, he's been ambulating, and he comes to you and says, this hurts. So this is not a primary case. This does not take 60 minutes in and out, and you run to your other room to do another case, or you go have coffee or see patients in the office. You have to plan a longer day in the operating room. These plates are old. They may break when you try to take the screws out. Screws may break, and then you can't put stems down. You may not have a screwdriver that even fits these screws. So you have to have your metal cutting burrs. You have to have instruments to cut metal. You need to have the broken screw set or the Winquist set in order to trephine over screws and take them out. The main goal is, in my hands, the steps. You always want to do your approach. You want to dislocate your hip. You want to put your hip back in, and now you want to take out the hardware. You don't want to take the hardware first and then try and dislocate the hip. You may cause fractures because you weaken the bone when you take out the hardware. And a dislocation is an aggressive maneuver of manipulating the hip and taking it out. So you want to approach, dislocate, put the hip back in, and then take out the hardware. My goal when I take out hardware is only to take out what I need to take out. What doesn't need to come out stays in. There's no reason to take hardware out that's not in the way. It didn't bother them. The hardware is not what's bothering the patient. So you can see the amount of screws. I think there were 16 screws in this case. You have a lag screw. There's 2 different plates there. So is it a primary or revision? I think we all agree it's a revision. You'll need a stem long enough to bypass the last screw by 2 cortical diameters, not to have a stretch riser that can cause a fracture. Approach in my hands is a posterior approach. The length of the case, this is not going to be a longer case. Try and utilize previous scars if you can. If they're old scars, stay 5 centimeters away and do another scar. You don't want to start doing crisscrossing of scars and then have tissue necrosis or problems with your thing. So the revision here was a long tapered stem. I took out all the screws. I left one of the plates. It wasn't in the way. It was underneath bone. There's no reason to dig it out. Acetabulum was straightforward. Multiple screws because a lot of erosion. You can see the length of the stem, the engagement, and follow-up images. The patient is doing well. Another case, 80-year-old female with right hip pain since open reduction osteosynthesis. Again, this is not a primary case. This will not be simple. You're going to have to do a long scar. You can keep the plate if you want, but you'll have to cut at least the top of the plate off. And you'll have to take screws. At that point, maybe it's just easier to take out this plate. It will be probably easier to take out the plate by cutting it and taking it out in 2 pieces. You can either take the top piece together with the entire bone and do a sliding osteotomy and try and repair it down. It will be hard to keep everything proximally. You can plan to do a femoral neck cut, use the head as an osteotomy, and then connect it with the stem to the rest of the femur. You can see the length. The femur is also, we can argue if it's a type 3 femur. We agree that this is going to need a long revision stem. Some people may use a proximal femoral replacement. I try and avoid them until the last minute. Type of revision stem, I use tapered stem, or you can use a cylindrical stem. If you want more of a filling stem, it's a cheaper stem. The older cobalt probe, fully porous stems, or 3/4 porous. How will you repair the greater trope? I did this case almost 10 years ago. I wasn't using the tapered stems then. This is a cylindrical, fully coated stem that's getting fixation. And the trochanter is fixed with non-absorbable sutures, number 5 fiber wires around. I don't like putting cables and wires around metal, and the proximal implant was exposed, so I use number 5 tape fiber wires and do figure of 8 fixation for the troch. You can use a troch plate as well as an option. You can see the fixation beyond the screws. This is a simple stem to do a simple operation for a complex problem. So that's a little bit more complex. 7-year-old male, history of acetabular fracture, proximal femur fracture, distal femur, tibia plateau. He was hit by a drunk driver 20 years ago. He was probably drunk as well. Yeah, I feel like you as well when I look at that. So the first thing to do is try to figure out which hardware is in the way and which hardware is not in the way. There's a lot of hardware around that acetabulum, but if none of the screws are in that acetabulum, if you look good underneath all the screws there, you'll see that the joint is still preserved. There's not a lot of arthritis inside of the joint on that acetabular side. The head is collapsed, and fixing this, my trauma partner said, we can't fix it, you need to replace it. The bad news was that the patient was very unstable, very sick during the operation, and my anesthesia partners are going to finish the case as quick as you can. That was the instructions I got. Do this as quick as you can. I look at them and say, okay. So you can see again the proximal femur, that's acetabulum. So you can see the CT, you can see the screws are not in the acetabulum, and there's still preservation of the joint space. So I'm trying to think what's the fastest way in and out, an old patient. So you can even consider doing a hemiarthroplasty and keeping the acetabulum away. This is a knee. He said he also wants a knee replacement. I told him, okay, come back in 10 years. So is this a primer or revision? This is not a primary case. This is not simple. Hemi versus total. So during the case, 45 minutes in the case, the anesthesia team says you have to finish, she's unstable, we have to get out. So I did a hemiarthroplasty. I fixed the proximal femur with one wire quickly, put a stem distally, took some screws out so I can bypass so I don't cause a fracture between the plate and the screw, and left the OR. Patient did okay. This is follow-up. And he's still okay. So sometimes you have to do things quickly. You just always have to have a plan. If you want to do these complex cases, have options, have plans. Let's go a little bit easier. Acetabulum fracture. So this is the fixation of the acetabulum. And this is what's happened later. The entire head is destroyed. My guess was there was a screw inside of the joint. The head's gone away. Patient is 80 years old, and I do posterior approaches. So what are the options? I can do anterior and have some screws taken out first, or I can go posteriorly and burn the screw out. Or there's a third option. No, not anterior. That's not an option. So you can see the screw in the acetabulum. 80 years old, screw, bone. That's the head. I cemented a dual mobility cup in front. Easy solution. I don't have to deal with the screw. I don't have to ream and hit the screws. 80 years old, well cemented, dual mobility head should do fine for this patient's life. Press fit stem, maybe I should have cemented the stem as well. 74-year-old male, right hip hemiarthroplasty for femoral neck fracture. So conversion of previous hemiarthroplasties are not always as simple as they look. The problem are a few. If you want to keep the stem and you have to ream the cup, you lose offset and you lose length. And you can't always compensate with the polyethylene and the head. Depends which head they use on the hemi. If they use a very long head on the hemiarthroplasty and you convert it to tall hip, you may find yourself unstable because of length and offset. So always be prepared that you may need to take the stem out. So this patient had instability and dislocations with a hemiarthroplasty. This stem is a ML taper. I find them not that difficult to take out from the top without causing too much damage. You can see the dislocation of the hemiarthroplasty. So I converted it, I took the stem out, I put a Wagner short stem inside, I did a new cup, and the patient was stable. I didn't touch the rest of the hardware, I left it there. And the patient did well to follow. Let's do one more. Patient has hardware, he has a contraction, an adduction contraction, a very unstable position for a hip replacement. Again, hardware has to come out, we have to convert that acetabulum as well. So this is another Wagner stem from a different company, a cup with a dual mobility cemented inside, so a fully porous cup in a neutral position for bony ingrowth, and a dual mobility cemented cup inside for stability. So a jumbo cup and a dual mobility cemented cup inside. I also released the adductor muscles percutaneously in order to try and release the risks of dislocation. You can see here the construct. The dual mobility head, the dual mobility cup cemented into the porous cup behind that. And this is follow-up. The patient was doing fine, developing some HO. Last case, two more. One, a nail. These cases are not always easy to take out the nails. Be prepared what you do if you can't take the nail out or it's causing difficulty. Sometimes you can do a distal approach and hit on the nail from the bottom, or try and grab it from the top. Before I try and take these nails out, I always pray, and then I hit it for the first time. If it comes out, there is a God. If not, I stay an atheist. And you can see the nail, old-fashioned nail, that managed to come out. I was lucky, bone didn't grow distally onto these teeth. If it grows distally, it's very hard. This is a partially coated, cylindrical AML type stem. Last case, post-traumatic arthritis. I have no idea why they put so many screws in there. but I have to take them out. So again, approach, dislocation, put it back in, take out all the screws, and then put a stem. I don't like, personally, I don't like using an ML taper, an anterior posterior taper, for patients that have screws or fracture fixation. I can use a primary implant, but I prefer a Riemann Broach filling implant that has a little bit lower fixation on the metaphysis. I think the proximal metaphysis is compromised for an ML taper, at least in my hands. So I use a Riemann Broach stem. It gives a little bit better fixation in the lower metaphysis area. The stems themselves are very stable. So I trusted more of that for bone that's not so good on top. That's it for this. I just wanted to add something for Will's presentation on the hip spine. There's some great papers out there, and I recommend reading them for understanding the simple thing. There's a nice paper in the Bone and Joint Journal. The author is Fan, F-H-A-N. Very simple explanation. We're all used to using the combined ana version, but we're not sure the combined ana version by itself is the right thing to do anymore in the hip spine. The way to think about it is that the position of your acetabulum prevents the head from coming out. The position of the stem can prevent the impingement of the greater trochanter on the pelvis. So one prevents impingement, one prevents the head from popping out. Just by giving one of them 40 degrees of anaversion, the other one 0, and you have 40 of combined anaversion is not the good choice. You have to understand what each one does, and you have to position them in the right place. It's very rare that you have the neck of the stem hitting the cup anteriorly and causing a posterior dislocation. Usually you have the greater trochanter hitting the pelvis and popping out. It's not always true on the opposite. Usually when you pop out the front, you have the neck of the stem hitting the cup more than the greater trochanter hitting the ischium, which can happen, but not as common. So always think about these things in a functional way. What is hitting what? Hips don't fall out. They impinge, lever out, and come out. That's the most common thing. So you have to keep that in mind. Thank you.